كده شايفين؟
ايوه كده مظبوط.
كده تمام؟
تمام.
اي
خلاص؟
ايوه مظبوط كده. اي
اوكي، شكرا يا انس. شكرا يا
العافيه
دسوق.
صادق.
الله يديك
Okay,
العافية.
let us start. It's always good to come back and always to hear these nice voices. And thank you for Yusuf. Yusuf Al-Badri is one of our registrar here was helping. It's Assalamu alaikum. Acute coronary syndrome, we just got to the basic. As usual, we tailor this presentation to the needs of the audience. And we were concerned about acute coronary syndrome because acute coronary syndrome, with all the variety of it, it carries high risk for sudden cardiac death, and they share the same pathophysiology. So today, we're going to concentrate on the pathophysiology of acute coronary syndrome. And acute coronary syndrome, now we are talking about SC elevation acute coronary syndrome and category of non-SC elevation acute coronary syndrome. The all groups of non-STEMI and unstable angina now where they merge to the what we call it non-SC elevation acute coronary syndrome. So there's no more anti-anginal in medicine. There's no non-STEMI in medicine. It's all non-SC elevation acute coronary syndrome. So the epidemiology of acute coronary syndrome is, we know that it's the leading cause of death worldwide. And in a country like United States, like 1 American is killed per minute due to acute coronary syndrome. And approximately about 8 million Americans have a history of MI. This according to all data, but it didn't change yet. We know that the cause of this worldwide is atherosclerosis-related diseases or cardiovascular diseases, the leading cause, especially among females. Although still people were previously feel that breast cancer might be one of the leading causes in the females, but still atherosclerosis-related diseases is the leading cause of death in all across the gender. Still, despite development in medicine and technology and the new innovation, it's still acute coronary syndrome or atherosclerosis-related diseases, or like especially the ST elevation acute coronary syndrome, it could be just presented with death. And this is an old slides from 1993. It tells you that at that time, up to 45% in women could be presented with just sudden death, and up to 62% in males. Things change now due to the awareness, the smoking awareness, use of statin, good control of blood pressure, new innovation in diabetes management. All this give us a good value of reduction of acute coronary syndrome, and presentation of sudden death is no more there. It's less. It is there, but it's not more high percentage and high burden. Very important for us to know that atherosclerosis is not selective. So you could get atherosclerosis-related diseases anywhere in the body, and at any time, if you have an evidence organ of atherosclerosis-related diseases like ischemic stroke or peripheral vascular disease or ischemic heart disease, this, if you had an evidence of any one of these, this puts that patient for high risk to get atherosclerosis-related diseases. I mean, like if you have a patient with a TIA, this is a risk factor for acute coronary syndrome. To understand the pathophysiology of acute coronary syndrome, you need to have a gasping idea about these three words: ischemia, injury, and infarction, and the difference between them. So this is called the triad of acute coronary syndrome: ischemia, injury, and infarction. Ischemia means a reversible damage or a reversible effect on the myocardium. Injury, that means it's an intermediate. It is an intermediate phase between injury and between infarction and ischemia. That means it's partially dead or partially reversible myocardium, and infarction is all about dead cells. That's why people try to have a paradigm thinking when you're dealing with coronary artery disease. By name it acute coronary syndrome, that means you have a chance to save and by chance to salvage a lot of myocardium. But if you use the word infarction, that the myocardium is dead and nothing needs to be done. So that's why people are going now towards acute coronary syndrome as a paradigm shift in thinking when we're dealing with what we call it myocardial infarction in the past. So what is the myocardial response to ischemia, or what happened when the myocardium get like affected by diminished blood supply? Because it's always about like demand and need and demand, and mismatch between them is what create the symptoms and create the whole spectrum of acute coronary syndrome. So you could have a stunning myocardium, and that happen when there's suddenly cessation of blood supply of a healthy myocardium, so that the myocardium itself is becoming stunned. Stunned is just becoming like a catatonic. It stop moving, and that's part of it, is to reduce the amount of energy and to use and to give time like for using the energy supply, which is like stored in the mitochondria of the myocytes, and that will help for more survivor, for the myocyte to fight for more survivor. So stunning myocardium, it could happen immediately after the cessation of the supply, and it could stay for a period of time, like you could find stunned myocardium for up to 36 hours. So preconditioning is a condition that where the myocardium itself with time get to deal with this mismatch of supply and demand. So if there's less supply, and the myocardium is kind of get used to that, and then get used to surviving that, and most of the time you might not have symptoms, and that's like your myocardium is get used to the ischemia and get used to the low blood supply, and there's a lot of theories around it, and merely giving collaterals, and most of the capillaries find their way to supply that area of diminished supply and take over, and making the right balance. So preconditioning is the conditioning where the myocardium is still viable, but and it gets used to less blood supply. Hibernation on the other side is a well-known phenomena. That's myocardium. It behaves like dead in the resting phase. So in a resting phase, when the patient is resting, you could do an imaging and feel that there is an area of like just not moving at all, or not as look like an akinetic. But when you push that myocardium, or that part of the myocardium with stress, like exercising or making like D vitamin stress test, or any sort of especially those who's nowadays with cardiac MRI, adenosine, or others. So any sort of exercise will recruit that part of the myocardium, and the myocardium will come to life again and function normally. So it's called a hibernating myocardium. It is not a dead myocardium, but at rest it's behaved like that. So it's all about acute coronary syndrome, and the understanding of acute coronary syndrome is that you are fighting against time. So the whole idea here is you are just fighting against time, and that's the famous phrase of Brian Wald, that time equal muscle in acute coronary syndrome. So the earlier you react, and you try to be positive in dealing with the myocardium, and that in a way that to revascularize it, and that's saving a lot of muscles. So the earlier you static that and you're doing that, the more you're going to save in terms of myocytes and thickness of the muscles. And this is in this slide that showed in 40 minutes time after a cessation of blood supply, only a small area in the myocardial area will be affected. After 3 hours, that might be like extended to the half of the myocardium, and definitely in 4 days time, whatever you're going to do a very good and necessary job. To understand also about acute coronary syndrome, you need to say that this condition doesn't happen just like that. It has certain factor could leading to it. Those factors could be divided in two. The one you could modify them, and the one you cannot modify them. So the modifiable factors is always the genes and the hereditary part of it, and the gender, and also the age. And those you cannot do anything with them, at least for the time being. But there's factors which could be modifiable, including smoking, hypertension, diabetes, the hypercholesterolemia, the style of living, the obesity, and controlling of chronic inflammatory diseases. All this, if you got on top of them, you minimize the risk for coronary artery disease and hence acute coronary syndrome. So I don't know what's happened over the years. I've always been this slide that I always feel there's something wrong had happened with understanding of medicine, and now we're getting the shortcut and going to Google and get the information, or go to our smartphone and get the answers. But I think medicine is always depending on deep understanding and grasping for the pathophysiology, for the etiology of the problem, and then hence the treatment will be easier, and even understanding it will be much easier. So the cardinal problem of acute coronary syndrome is all about atherosclerosis. And to understand atherosclerosis, you must know that atherosclerosis is a very slowly progressive phenomena, or of inflammatory process. The very inflammatory. So an injury to the endothelium will trigger atherosclerosis. The effect of that injury could happen and could cause a trouble in 20 to 30 years time. Is that slowly progressing. So it had phases, but all you need to know that it goes a long period to cause trouble. So and then if you want to have a good idea about it, you should know that atherosclerosis could start in utero. So there's a lot of fetal biopsies taken, and that showed that, especially in patients with familial hypercholesterolemia, that they have evidence of atherosclerosis in utero, in the baby in the womb. Still, they could find that. And as I told you, there is no age group is protected, or is immune against atherosclerosis. And in this study, you find that this group of patients were collected as autopsy from the middle cerebral artery, and I think from the LAD in the coronary artery tree, and something in the dorsalis pedis of those road traffic accident victims. And all of them, they get from these 3 samples, and they get histopathology to see if there is evidence of atherosclerosis. And surprisingly, as people as young as 12 and 13 years of age, they still could have atherosclerosis in the sample collected. And that the older they get, the higher they'll get the chances to develop, there will be sign of atherosclerosis. So how atherosclerosis happens? This is a very famous style. Some of you probably have seen it before. This is just a cross-section area of the lumen and the intima, and as well as the endothelium of an arteriole. So this is the lumen. This is the endothelium, which is a thin leaded layer, and this is the subendothelial matrix, and this is the intima. So to develop atherosclerosis, you have to have an injury to that endothelium. This is, let us say, the offending is an excess LAD in the body, and that injury and the endothelial injury will create an inflammation. As far as the LAD is showering inside the injured area, the body will try to contain it, and as a normal inflammatory process, and then infiltrating myocyte will appear to contain it. And as the time goes by, more infiltration of LAD, then there will be conformational changes and sizing changes in the monocyte, and they'll change to macrophages, as all well known, and these macrophages will try to engulf the LAD. And over the years, this engulfed LAD, and with the macrophages, they form what you call a fat streak under the endothelium. And all this happening, and we don't aware about it, because this is a very slowly and tedious process. So as the time goes by, underneath the fat streak will get bigger, and there will be more cytokines secreted by the rupture, or even by the live macrophages, and that will be more chemotactic to more macrophages, and more cytokines, interleukin 1, interleukin 2, interleukin 6, and all these inflammatory markers. As this happens, this will signal that there's a problem in that part of the artery, and the intima, and the smooth muscle of the intima will try to to migrate and contain that problem as a protection for the intima itself. So there will be more small, the small muscle cells will get also conformational changes. They'll become more migratory, and they will become more larger in their sizes. And as this goes by, the deposition of certain minerals, especially calcium and phosphorus and magnesium, bismuth, all this will precipitate in the plaque under the endothelium, and this will call what we call is still a fatty plaque or is still a soft plaque. And as the time goes by, more smooth muscle will travel to contain it, and the thin leaded layer of the endothelium itself will become a bit fibrotic, and to contain this, not to go toward the lumen. All this like an inflammatory protection from the body. And as the time goes by, the center of this plaque will become a bit necrotic with all these macrophages in it and all these cytokines. And as like necrotic, like a bus, like a small abscess which need to be drained somewhere, and this always goes to the weakest link, and the weakest link will be the upper part of at the junction of the normal endothelium to the fibrotic cap, and this at that time this will what we call all the hell will broke loose at that time, and that's another protective manner of the body will come to contain that bus not to go into the lumen. So that there's a crack in the plaque will encourage platelet, which will come and adhere and try to seal that crack. So with adhesion of the platelet and attraction of more platelets and adhesion of more RBCs, they will form what we call it a seal. And that seal, it depends on it. It would cause a problem. If it has become like a big thrombus and a small artery, you got the symptom. If it is in the brain, you might get the headache, the TIAs, and even the stroke. If it is in the coronary disease, you might get the acute coronary syndrome. It could be, if it is fully block the artery, it will be ST elevation acute coronary syndrome. It's partially occluding the artery at that part of the site of the myocardium. It will be an ST elevation acute coronary syndrome, or it could be just distal in the legs and causing peripheral vascular disease. So this is symbol. What about atherosclerosis? And then we talk about the plaque, because fortunately not all the plaques formed in our body will rupture and cause atherosclerotic related diseases. And the reason behind that, because we have two types of the plaque. We have a stable plaque, which is going to be like there and not going to be ruptured. And if it's going to cause, it might cause hindering of the blood flow, but it's difficultly and very rarely to cause like acute diseases. What form the stable plaque? The stable plaque is always having a thin, a small core, a lipid core, and abundant of myocytes from the intima, try to contain that small lipid center, and also it will have a very thick fibrous cap as caused by chronic inflammation, and the endothelium is tend to be changed from the endothelium layer to a thick cap and less foam cells in it, and that's what's called a stable plaque. And stable plaque, as I said, usually it grows slowly. It grows like over decades, 1 or 2 decades, or maybe 3 decades. I might not even cause any trouble. But the problem is that if this process of atherosclerosis is a bit accelerated with a large lipid core and a thin endothelial layer, a thin fibrous cap, and less abundant of myocytes around it to contain it, and with excess of inflammatory cells, this will form what you call a vulnerable plaque. Vulnerable plaque is that what had the tendency to rupture and cause a disease according to the site according to the site. This is another view to have a grasp about what called vulnerable plaque or unstable plaque and stable plaque. You see here stable plaque at the bottom have a thick fibrous cap and a small lipid core, and that's around, and still the lumen is narrow. It causes hindering of the blood flow, but the fibrous cap is thick and the myocytes containing it, and they are very unlikely to rupture. Compared to this on the top, which is called the vulnerable plaque, which usually happen in an accelerated way, and has a very thin fibrous cap, a big core lipid, and like will be abundant inflammatory markers and less smooth muscle cells. Smooth muscle cells, I was talking about it all the time. When I say myositis, I'm meaning the smooth muscle cells. Okay? So, like, whenever the plaque rupture, then there will be the function of the platelets is playing a pivotal role in acute coronary syndrome, and the platelets is themselves they have four phases for action. So the platelet had to be at heat, and when they heat in the platelet which look small, when they heat they become activated, and when they activated they become like tens times or 100 times larger than the normal size and become more 100 times chemotactic, and more that will attract more platelet and more RBCs. So the platelet they need to adhere first and then become activated, and when they activated, they recruit more platelet, recruit more RBCs, and become like abundant in the area. So they need to adhere and then activate, and after activate, they need to aggregate. Aggregate, that means they just be matted together, and when they mat it together, they form what's called like a thrombus, or like a bulge above that crack area, and that could have causing to thrombotic embolism, total thrombotic occlusion, which could be total or partial on that arterioles. This is just another way to look to the platelets before when they adhere they're smaller, and when they activated they become more larger chemotactically and in their size, and that when they become aggregated they look like that. So this is like how the platelet like merge together, how do they mat it together. They mat it together through the GB 2B 3A receptor, and that receptor like just they had through the receptor they mat it to each other, and if to prevent them you have to use a GB 2B 3A inhibitors, which is like usually a very expensive antiplatelet and had to be given parenterally, not orally. So you could see here the additional slide just to show you that how they mat it together, the platelets through the GB2B3A receptors, and then the fibrinogen molecules will come and contain them together. So this is how when with the abundance of the presence of the fibrinogen, with the presence of activated platelet, and thus matted ones, they form the thrombus, or called fibrin, because of the fibrin like work like they matted them together. They need the fibrin to do that and forming what you call fibrin mesh. Okay. So the antiplatelets, if you want to use antiplatelets, you have to know what phase of the antiplatelet you are targeting. If you are using aspirin and clopidogrel, probably you're using ticagrelor, which is what's available now. I think this is in Sudan. This targeting platelet activation. To target platelet aggregation, you need to use like injectable medication, which is like what you call them GB2B3A inhibitors that prevent platelet aggregation, like abixibas, injectable medication. You don't sorry.
Agrestat,
Agrostat is one of them. Yes.
Tyrofiban.
Yes. Tyrofiban and agrostat. So this is just to show you that like how the thrombus itself, when it is formed, it's not always staying in the same position. It could migrate to distal part of the arteries of the vessel, to the distal part of the vessel, and including the distal part of the vessel. So you could have the atherosclerosis at the proximal part. At the proximal part of the vessel, but you could find distal part of the vessel, there's no flow in it, and that's been excluded by what you call distal embolization. So, okay, to understand platelets and their function, you need to know so that there's certain things help the platelet to function more, mainly the collagen, and especially when they stick to collagen 4 and collagen 6, they become more activated. So that they tell the activation. ADP also, adenosine diphosphate, activate them. That's why we use clopidogrel to guard against that. Thrombane for it could activate platelets, and we use aspirin to guard against that. Stress in general, the shearing force of high blood pressure, are all these things during the events might lead to more platelet activation. This is a busy slide just to tell you the site of thrombotic drug action, if it is low molecular heparin or like new drugs like biruvidine and like the aspirin and the and the clopidogrel. Okay, so there's what there's platelet activator, what you call them, BY2 inhibitors, and then mainly the clopidogrel, prazoquel, and ticagrelor. And these ones, there's much difference between them. And the most important thing is just to know that uh, the reversibility is that only ticagrelor is reversible. Prazoquel and clopidogrel are not reversible at all. And the duration of action that clopidogrel could stay in your body up to 10 days, and roughly it is 5 to 7 days, but it could stay up to 10 days, while ticagrelor usually need one to 2 days to clear, but it could stay up to 4 years. And prazoquel is the same like clopidogrel. So if you understand the pathophysiology of the acute coronary syndrome, you need to know that there's classical symptoms for acute coronary syndrome, but sometimes it comes with atypical symptoms, and all you need to high index of suspicion when you're dealing with patient with risk factor and coming to you with chest pain, and if by chance you have a positive troponin, that will track your action to it. But the presentation could be silent, especially with patient who's having like diabetes, neuropathy, advanced renal problems, advanced uremia. All this could sometimes they came with silent acute coronary syndrome. The differential diagnosis, you don't need to you need to put it in your mind all the time, because not all the ST elevation are due to acute coronary syndrome, and not all the chest pain are related to acute coronary syndrome. You need to put on your mind aortic dissection, especially in inferior myocardial infarction, inferior ST elevation acute coronary syndromes, BEs, pericardial tamponade, esophageal ruptures, and tension pneumothorax. These you need to be in mind all time when you are dealing with acute coronary syndrome. This is just an ECG to tell you like how we will categorize them, or how classify acute coronary syndrome between inferior, anterior, and anterolateral, or subtal or anterosubtal. So each group of a 12 ECG is reflecting a certain area in the coronary circulation, and this is how you need to get your eyes customized to the ECG finding of ST elevation, because ST elevation is a catastrophic if you missed it. And we need to have high index of suspicion for any patient you feel there's high ST elevation. If you cannot judge this is ST elevation, acute coronary syndrome or not, please call your senior. So in net elevation acute coronary syndrome is usually the T-wave inversion or repolarization changes will be like horizontal or just down sloping. The up sloping part of it could be a normal variant. It could happen a lot during exercise, and you notice a lot in exercise stress testing. This is how S elevation look like. And then when you have this extensive myocardial infarction with extensive anterolateral S elevation MIs, you should feel the creeps, and you should just track as swiftly as much as you can. Another ECG, this is an ECG just to tell you that is not always, you could get the diagnosis just from a classical 12 ECGs. Sometimes you need to do what we call it a right ECGs, and a right side ECG, and this is just to sometimes mainly when you want to define a posterior extension, and you could know here in this ECG that the S elevation in lead 3 is higher than lead 3. And there's always in lead 4 or 5 there will be an S elevation an S elevation in that reciprocal leads, or the reciprocal finding in V2. So, okay, that's long. Just I would like just to talk here that if in an area in Sudan where we have limited resources, we need to put our resources to get the maximum out of it for the maximum benefit of our patient, and you don't let to every effort we need to put it on the right place. And acute coronary syndrome need a special attention for us and aiming for early remobilization for S elevation acute coronary syndrome. Okay, this is the management. I think these reperfusion strategies are not going to go for it. I think I stop here if you don't mind. Do you have any question, or if you have time?
Thank you very much, Sadik. Complex and talk. You managed to do it in a short time. حقيقي. Very difficult talk usually, the pathophysiology. As the ground is open, if any questions or any comment.
Any question, Irfan?
سموال.
Do you have any question about the pathophysiology of ACS? The floor is open. Any question? Tough and in a quick time, Dr. Elsadig, as usual, have explained all about acute coronary syndrome, the pathophysiology. And I think the audience, okay. Prof. Saidi.
Okay. So no questions from the floor?
No.
Hello. Dr. Anas.
Alaikum salam.
Thank you very much, Dr. Elsadig, for comprehensive talk. I would like to ask Dr. Elsadig for the underlying cause and risk factor for acute coronary syndrome. Is there any role for infective cause for myocardial infarction, and how does it occur?
It's okay. It's all the chronic inflammation, rheumatoid arthritis, thoracic arthropathy, inflammatory bowel disease, all this chronic inflammation secrete a lot of cytokines, which could damage the endothelium. Anything could damage the endothelium that will lead to atherosclerosis related diseases. It's not necessary to be like acute coronary syndrome. It could be like a stroke. It could be peripheral vascular disease, or even acute coronary syndrome. So inflammation in general, chronic inflammation in general, will trigger some sort of endothelial reaction, endothelial injury, which will create atherosclerosis reaction. And inflammation itself, it will lead to acceleration of the process of atherosclerosis. And it's not uncommon in the past to find people coming with sepsis or with septic or cholecystitis, for example, and then at the same time develop some sort of acute coronary syndrome or TIAs or anything, because the inflammatory process was brewing يعني بتخمر, brewing in the body and we're not feeling it. And then out of the sudden abundance of these inflammatory cytokines, and that could lead to rupture or acceleration of the plaque and lead to an early rupture. But not infection itself. Like in the setting of infection, in the setting of sepsis, usually you need, and there is no cardiopulmonary symptoms, that could be like what you call it type 2 MI, which lead to a raised troponin without a real myocardial injury.
صادق.
الو
السلام عليكم.
وعليكم السلام. صلاح ازيك
ازيكم؟
يا ابو صلاح؟
الحمد لله. والله يا اخي الزول يعني ما تعرف انه الدموع تنزل بجد يعني. فقدناكم كيف وانجوي. اول حاجه محاضره انس ومحاضرتك رجعتونا الايام الجميله والله. وربنا يجزيكم خير ويقويكم ويخليكم دائما على صله ببلدكم. يعني بعد الجسم لا يعني شيء، بروحكم معانا ان شاء الله. والشكر الجزيل لاخواننا في كسله، لاخواننا في الربيط، وكسل على راسهم اخونا السمول تاج الدين والدسوقي، وكتر خيركم يا جماعه. I did enjoy every minute of it. شكرا يا صادق.
تسلم يا ابو صلاح، تسلم يا اخوي.
Dr. Elsadig, as usual, very fruitful talk. What about non-atherosclerosis? Is so spasm, stressful conditions. So would it be يعني اخد جانب كده من الطقس بقى كده؟ So stress can lead or coronary spasm. We have seen a lot of cases following administration of adrenaline in resuscitation. يمكن يكون في كسر هنا كم زول. فدرجات STD with coronary spasm. ممكن to highlight on it.
Yes, coronary spasm is well documented. It is well يعني it is well known in literature and in real life. Coronary spasm it's something real, but the coronary spasm itself, there's always the thought that our artery wouldn't spasm by its own. Like usually we have underlying underlying problem, and the underlying problem is it could be of some sort of ongoing slow process of atherosclerosis contributing to it. Is not affecting because it's not affecting the lumen. It's brewing in the wall of the artery, and that's the presence of all these cytokines sometimes in the wall of the artery lead to spasm of the artery, despite that the lumen is still clear, you know. So like there's a lot of thought in it, but I myself believe a spasm wouldn't happen in a normal artery. Always that artery had to have some sort of inflammatory process going inside the wall, or sparing the lumen at the time of the spasm. And when you do the coronary artery, you delineate the coronary artery, you find a clear lumen. But like that doesn't mean that you don't see that doesn't mean the walls are clear.
برضه انا عايز اقول حاجه انه Dr. Elsadig is the president of Sudan Heart Society, and I was with him in the في الفيس، وكانت اول محطه لنا انه الاكاديميك اكتيفيتي تكون كسله. برضه ممكن يكون هو مربوط بكسله واختياره ليها، واكيد دكتور صفاء برضه قالت انها هي she was growing كسل in early life. فبرضه لان اذكر الكلام ده وانا بقوله، وبذكر انه هو بيقول انه كان اول حاجه في الاعلام كنا مجهزين برنامج قوي جدا انه نيجي نقعد for 0 or 5 days في كسله، ويكون فيها continuous education وتريننج. لو تتذكر يا دكتور صالح.
والله اتذكر كويس، يتذكر اخوي سعد صباحي يعني كان يوليد البروجرام في كسلة. كنا حنجي بالضبط كده في شهر 6 في كسلة، هو يعني شهرين بعد الحرب دي كانت البروجرام اللي نجي كده 6، والجروب كان ليدر سعد صباحي اخونا سعد، وانا كنت في الجروب. والمهم يعني كانت يعني الحمد لله ان شاء الله ترجع بلدنا، ونرجع لكسلة، ونرجع للخرطوم، ونرجع للمرمان، ونرجع كل البلد ان شاء الله. And I would like just to add, you know, like if you don't know to deal with acute coronary syndrome, please load the patient with aspirin, clopidogrel, and send him to a place where they could deal with the acute coronary syndrome as soon as they can. بحمار، بكارو، بلوري، بأي حاجة. فبليز يعني don't delay. The delay is not going to help. As I said earlier, time equals muscles, and we need to do it. We need to just react swiftly, and just the loading of aspirin and Plavix is crucial. If you think this is acute coronary syndrome, just do it. Get the ECG as early as you can, and try to send it to an area where they could benefit from early revascularization. Early revascularization, or like the doom streptokinase, the doom primary BCI, the earlier the better. Assalamu alaikum.
Another question. We noticed that the patient with using clopidogrel, hemorrhagic manifestation is common, very common among patients with using clopidogrel rather than aspirin. How could you explain?
No, like clopidogrel is rather safe. What the combination of them, increase the GI bleeding. Yes, the GI bleeding increase the intracranial bleeding, but the benefit outweigh the risk. This risk. So like acute coronary syndrome, they need dual antiplatelet for a year, and we should strive to give them the dual antiplatelet for that year, because the body will stay for a state of hypercoagulopathy and tendency to develop another acute coronary syndrome for long period of time after the event you are dealing with. So sometimes up to 6 months, people saying that. But like the guideline recommending you to give clopidogrel and aspirin for a year, minimum a year in acute coronary syndrome, regardless the spectrum of the acute coronary syndrome. If it is non-ST elevation acute coronary syndrome or ST elevation acute coronary syndrome. If you put a stent or you didn't put a stent. If you had a surgery, you didn't have surgery. So you have to go for a year, regardless the patient what he had, how he managed. He get a stent, he get the bypass surgery, he get thrombolytic therapy and then medical treatment, whatever. Like he had to stay for a year. During this year, you need to protect them with PPI if needed, if you feel the risk is high, and it's recommended to use pantoprazole.
Another question is possible. Assalamu alaikum, Dr. Elsadig.
Wa alaikum assalam wa rahmah.
Thank you so much for these elegant lectures. You mentioned about the atherosclerosis, which is very complicated when starting, and it is starting very early age, as you mentioned. Is there any protective measures for the young people that it can stop this atherosclerotic condition or the progression?
Yes, طبعا ايوه. هو the whole idea is انك to control the risk factors if you have risk factors. If you are smoking, you need to stop smoking. And by the way, smoking is not just not related to the number of the cigarette. It's related to nicotine. Nicotine is labeled as toxin to the endothelium. Whether you get it passively, whether you get it like in shisha, whether you get it in smoking in one cigarette, when you get it in 10 cigarettes. So you avoid nicotine at all. Nicotine is toxic to the endothelium. So we should never ever subject our endothelium to nicotine. If there is nicotine, you should run away, because you never know. One inhalation of a small amount of nicotine could create a reaction that you be uprise after 20 years from that day. So smoking cessation, get on top of your lipid profile, get on top of control diabetes, inflammatory processes, inflammatory diseases. You treat them well in rheumatoid arthritis, arthropathies, all this kind of chronic inflammation and diabetes and hypertension, and that will help us to control, to minimize the risk of acute coronary syndrome on those subjects having those factors. And on the other hand, there's a lot of, I don't want to complicate this, but there's a lot of research is going to detect vulnerable plaque, which the vulnerable which can rupture at a day, which that include a lot of these now. What you call it intravenous ultrasound, you could get it with IVUS, you could get it with OCTs, it might help. You could get it sometimes. We may use mixture with MRIs, like with MRI during the procedure, and all this, and then there's a clever idea of what you call a thermo mechanism, where you pass a wire at the tip of it. There's a tip which could check the temperature of the artery, and as you go, that's the temperature labeled on your artery. When you find an area where there is raised temperature, that means there's an inflammation in that area, and that there's a possibility of a vulnerable plaque in that place. The science is going, but like the whole idea here with what we can do in our country is to modify and get on top of the risk factor and raise awareness about coronary artery disease, and awareness about smoking cessation, awareness about good blood pressure control.
Okay, thank you so much. Thanks.
Hello. If no questions, have a break for break, and then we'll be back after 540 minutes. 540. For me.
Hello, thank you very much. Shukran.